The gram-positive bacilli that we have to worry about, or the aerobic gram-positive bacilli, it doesn't constitute a very large group of organisms, but we do see them a lot because they're normal flora in several areas of the body, and or they're contaminants, common contaminants that we've seen. And so we're going to go through Bacillus and Corynebacterium in this lecture. So we're going to start with Bacillus, which has a very clear, it's an aerobic gram-positive spore-forming bacilli. And it does produce an endospore. So there's a spore within the actual structure of the rod. Okay, it is aerobic and it's pretty large bacilli. When you look at it, it's pretty large. This is almost always a contaminant. We do see bacillus. One of the common places we see it is in blood cultures when you don't clean the top of the blood culture before phlebotomy. It is a very, it's everywhere. It's ubiquitous in the environment, or dirt and all that stuff. You'll find it there. There are only a couple of clinically significant organisms, and that's Bacillus anthracis, famous one, and Bacillus cereus. Those are the two clinically significant organisms, and we'll go through them separately. Okay. Bacillus anthracis, as you know, causes anthrax. Bacillus cereus actually causes a significant amount of food poisoning, which actually results in similar symptoms to what we see with Staph aureus or something like that, food poisoning. But we don't test for food poisoning in the laboratory. In order to test for food poisoning, you actually have to culture the food, not the person, okay, to prove that it came from them. The biggest problem with bacillus is the endospore. That endospore, which exists inside the organism, it's actually it's like a protection for the bug. It's a very resistant structure that actually contains an extra copy of the organism's genome, as well as some metabolic components that it's going to need. And it allows the organism to survive harsh or poor environmental conditions. Endospores are resistant to heat and to chemicals. They have that thick outer coating. It's actually made of keratin. And it'll also, because there's keratin there, it'll resist staining. So on gram stain, you usually see them as like a blank spot in the organism, okay, but it's still spore shaped, okay. But with these organisms produce these things so that following a fire or something like that, they still have a structure that allows them to continue. Even following a drought or something like that, they still have a structure that allows them to continue genetically. Because that spore is in there with the keratin, we have the spore stain, which is specific to force the stain into that endospore structure. So you add heat to the process, and you can see here that you have your glass slide on top with your stain. We usually use brilliant green, and as long as you do that over steam heat, it helps to force and you usually have to leave it there for 2 minutes or so, 2 to 5 minutes, and it'll force that green into the endospore. Then you take it off, let it cool, and then you just actually you rinse, and then you can counterstain. You don't have to counterstain, but most places we do counterstain with safranin. And then you can see here on the cell, you can see the endospores that are inside the cell. So we're going to go through the two different organisms from bacillus that are a problem. Anthracis is, of course, it's the most notorious pathogen of the group, but it's found everywhere. It's in the soil. Animals carry it. It can be in their gut and stuff like that because it's in dirt. Okay, so we come in contact with it all the time. the diseases that were caused by Bacillus anthrax were fairly common before we had modern antibiotics, first of all, in treatment, but also people didn't clean themselves, modern hygiene habits, okay? And so it caused the Bacillus anthracis could cause these wounds, which are called wool sorter's disease or ragpicker's disease. And that, it's actually cutaneous anthrax, which is the most common form of anthrax. And what happens is the spores, which are on dirt, they actually get forced into you, usually by some kind of contamination, some kind of, inoculation, trauma. You get a splinter, you get poke with the spine of a pricker bush or something like that. And then you can create a localized infection in your skin. Unfortunately, it can also, if you breathe in the spores, it can also cause anthrax pneumonia. And in 2001, there was an attack on the United States using the U.S. mail, where the anthrax was the anthrax, but what was actually weaponized was the powder. So the powder was weaponized in the sense that it was easily became and maintained an aerosol. Okay. Any other bacillus that we find, and you might find other bacillus besides Cerus, besides anthracis, they're considered opportunists. We're not worried about them. Okay, we just call them bacillus species and move on. That 2001 bioterrorism event occurred. It started obviously in the mail, and starts here. You can see in early October. And what happened was these envelopes were filled with a powder and sent through the mail, and the powder was able to move out, and there was probably powder on the outside of the envelope, and the powder was able to be transferred just through contact to other letters in the sorting units of the mail. And you can see at the end of the line, we end up with the targets. These were targets in the mostly in the media, but also in a couple of senators' offices. These were the intended targets of the anthrax. And unfortunately, that's not what happened. They weren't the ones who necessarily got it. The organism itself, again, is a large gram-positive rod. It's greater than 1 micrometer in width, and the spore inside does not swell the cell. Okay, so it's a very tight cell. It will grow fine, actually quite large, on your blood and your chocolate. It will not grow on CNA, and it will not grow on MAC. Okay, there is a special media called PLET, which it could also grow on PLET. Most of us don't keep that because it grows fine on blood and chocolate. If you look at it here, it is just a very large, flat, and it has like a ground glass surface appearance. The key things about anthracis is that when you're looking at the plate, and you can see it here on this plate, there is no hemolysis. It's hemolysis negative. Most of your bacillus actually will hemolyze, so when you see a non-hemolytic bacillus, we start to get a little bit nervous. Okay. It'll also be catalase positive and motility negative. Unusual also for motility. For most bacillus, they do have some motility. When you look close up, you can see that they look much more white, and it's considered a medusa head structure. That's the how they describe it. So you have this central portion with these little squiggly arms that are reaching out. They call that the medusa head. It's also a very tenacious colony, so it sticks to itself very well. You can see you can actually, the colony, it kind of just adheres to itself very well, and you can see it still stick up like that. Okay. There are other colonies that will give you the tenacity, but the medusa head feature with the dense central area and then the squiggles out from that. That's pretty characteristic of anthracis. The key thing is that you have to be aware that this is a possibility. Okay, before 2001, truly we never looked for bacillus in sputum. We just didn't. It wasn't something that was considered high risk here in this area of the country. Now we watch for it. Okay. What you're looking for are those non-hemolytic colonies, those large, flat, granular non-hemolytic colonies, and that they are non-modal. There is a test available. This is actually a direct test. It's called the red line alert test here. We wouldn't use this in the laboratory. It's intended for rapid presumptive identification of Bacillus anthracis. So this would be used basically, well, we could use it, but it's usually used more by State Department. You know, they're the ones that are doing all that testing. People find powder and get all nervous. So most of the stuff is used in like public health hospitals. But you can take those tests, those colonies, and you use this red line alert test, and it's a presumptive identification of Bacillus anthracis. The key thing is once you do your motility, you do your catalase, and you look at your beta hemolysis. If those are negative hemolysis, negative motility, and positive catalase, and it's a large gram-positive rod, you have to send it to the state. You have to call the state and tell them that this is a possibility. So you have to submit it to the public health officials, like right away, okay? And you have to notify. You're not going to send something to the reference lab, and the reference lab in this case would probably be New York State Department of Health, okay? But you would not send this out without letting them know that it's coming, okay? The disease that it causes three types. Cutaneous, again, most common. That's the wool sorters or rag pickers. Now, it's called that because there's a pretty close association between anthrax and sheep. And a lot of that has to do with sheep are not very clean. They have the thick wool that actually is able to maintain the bacteria, you know, so much, and the spores within it. And then what do we do once a year? We cut all of that wool off, and in the process our cuts and stuff can come in contact with those spores, and we end up with, you can see these cutaneous lesions here, okay? It's a pretty deep wound with a black necrotic edge called an Escher right here. And that's pretty characteristic of cutaneous anthrax. But highly treatable. That's not something that you have to worry about. And it's not that this would be easily transmitted to another person. Of course, you could work really hard at it, but it's not easily transmitted to another person because you've got the vegetative cell in here, not as many of the spores. The second type is gastrointestinal. But before I leave cutaneous, just to talk about the morbidity and mortality. If you don't treat the Escher, the mortality rate is 20%. So that's pretty significant for a wound like that. But if you treat it, it's almost 100% survival, okay? The gastrointestinal, however, it's a different kind of disease. You ingested the spores, okay? This is very rare in humans, but most patients will die from toxemia and sepsis in gastrointestinal anthrax. Basically, the spores can affect any part of the gastrointestinal tract. It could be the throat, the esophagus, stomach, intestines. It could be, the spores could take root in any part of those. And it has the same same number of days, between transmission and infection, about 1 to 7 days after you're exposed, you develop gastrointestinal sepsis, which usually does demonstrate with toxemia and sepsis. So the bug is growing in there and you have toxins in your blood because the bug is actually plugging along fine in your intestines. Without treatment, more than 50% of patients will die with gastrointestinal anthrax. Even with proper treatment, 40% will still die. So only 60% of patients will survive. And that's really the effects of that toxemia, that sepsis. Now, inhalation pneumonia is the one that we probably all think of. It is the one that made the news in 2001. This is where you inhale the spores. You're working with wool, raw wool in a mill or something like that, or maybe you work in a slaughterhouse with hides. This is where we see it most commonly in slaughterhouses, tanneries, and wool mills. The patients breathe in the spores during their work with contaminated animal hides, and the spores are able to take seed in your lungs and move to the lymph nodes in your chest before they move to the rest of the body. Eventually, you will have severe breathing problems and even shock. This is the most deadly form of anthrax. Again, the exposure, it takes about a week for the symptoms to develop, but they have seen cases where it's taken up to 2 months for the disease to develop. Without treatment, the mortality rate is between 85 and 90%. And even if we have aggressive treatment of patients, only about half of the patients will survive. So even with treatment, you have a pretty high mortality rate. Okay. The most severe form is inhalation, as we talked about. There's a lot of reasons for that. The organism itself has a couple of factors that help it, virulence factors. First of all, it has a glutamic acid capsule that it forms, and glutamic acid on its own can inhibit phagocytosis. And then, of course, the organism is able to secrete the anthrax toxin. Anthrax toxin is directly cytotoxic, so it'll directly kill human cells, and it'll cause edema, swelling, fluid accumulation in the site where it is released. Okay. In the lung, those spores that you breathed in, they're going to germinate, and then the vegetative cells, which is the growing cell, will start to secrete the toxin. And so the first place that you'll see effects is in the respiratory system, because of course that's where the toxin is initiated. Then the toxin spreads through the blood, and that's where you usually have death. Okay. Most inhalation anthrax patients die even with supportive care and use of antibiotics. There have been improvements that actually came about from the 2001 outbreak, and they think they've increased survival rates using drugs and stuff like penicillin, doxycycline, and improving the supportive care with the current respiratory technology that they have. There are vaccines for anthrax. The vaccine is available to select military persons, researchers, and also to people who work with animals, like even vets and stuff, but like farmers and stuff like that. It doesn't spread from person to person, so we don't see that. We only seem to get it through the spore that we got from the animal, but the disease obviously that it causes is so significant that this is definitely something you need to be aware of. The vaccine is not generally used in the general public, only because the risk is fairly low. Then we have Bacillus cereus, and this guy is looks the same with the exception of the fact that you can see it's beta hemolytic. This is definitely a beta hemolytic organism. It's still similar. It's found everywhere. It's in the dirt. You know, it's everywhere. Okay. But we have seen cases of food poisoning associated with this organism, and it does produce a toxin itself. It produces a diarrheal toxin and an emetic toxin or vomiting toxin, one that causes vomiting. We've also seen infections associated, interestingly, eye infections, especially traumatic eye infections. You know, so there's trauma to the eye in some way. You know, you get if you think about it, you know, two guys get in a brawl outside a bar, they're rolling around in the dirt, and a guy gets punched in the eye or something like that. You're probably going to implant some dirt in that punch. Unfortunately, from these superficial infections, it can lead to endocarditis and bacteremia. And they have seen bacteremia and endocarditis both with especially IV drug users and reusing that needle. Very dangerous. So the things that you see here, this bacillus would be somehow associated, it's usually the lettuce or something like that, growing there, and it gets into your intestines, and it's going to cause pretty serious food poisoning. To identify this, it's still a large gram-positive rod, and you can see it down here. This isn't a gram stain, but it's very large. It has the spore that doesn't swell the cell, and it is penicillin resistant. It will, it's a pretty large, like sort of feathery colony. But one of the things about Bacillus cereus is you might see some contamination, like a couple of colonies on your plate. That's not something you would need to worry about, even in a stool. Okay. If you have a stool that's full of Bacillus cereus, that might be an indication that the patient had some food poisoning. But the only way to really verify food poisoning is really to culture the food, not the stool. Okay. Obviously, in like a place like a canning facility or a bottling facility, we would be worried about Bacillus cereus, and that is something that we would want to be able to identify in one of those places, because we don't want food poisoning out of our factory. Okay, and so there are some augers that help you to directly identify Bacillus cereus. We don't generally use these in the laboratory. These are more commercial in nature. But you can see them here. We have the MYP, which is mannitol egg yolk polymyxin. And you can see that the Bacillus cereus grows pink on that agar. Then we have lecithinase, which is, it's actually a modified egg yolk agar. And they grow, you can see here, they grow pink on there as well. And Buccara is a chromogenic agar. And that's, they grow like a pink-orange color on that. Okay. So Bacillus is actually pretty easy to identify. So is Corynebacterium. These are not very difficult to identify, and for the most part, we don't really worry too much about Corynebacterium. They're not very interesting to us. Skin flora, normal skin flora. Another term for these gram-positive non-spore forming palisading rods are diphthoroids. Okay. They'll generally be catalase positive. And there are two basic groups of them, the lipophilic or non-lipophilic groups. We do have specialized media for them because there are some pathogenic strains here. But for the most part, we don't really use the special mediums. We talk about Lophalers is the special medium because they grow really fine on blood and on TSA. They're fine. They're fine. There's more than 60 species of Corynebacterium. Most of them are considered contaminants. Okay, if I tested your skin, I'd probably find Corynebacterium easily on it. Loeffler's media is a specialized media, and we do use that for, well, we don't keep it in general labs, but you could use it in labs if you wanted to specifically target Corynebacterium and the pathogens that that are there. On the agar, and you can see here on this plate, on the agar, they tend to be a little bit, they'll grow in 24 hours, but they'll be kind of small at 24 hours. They'll be dry, white, pretty bright white looking colonies, and generally gamma hemolytic, no hemolysis. When you see this, I mean, you could do a catalase, and it's catalase positive, but this is too small. It looks too small to be a staph. So you would do a gram stain. And on the gram stain, you would see the palisading. Remember, they call this Chinese letters. I don't see the Chinese letters, but I do see, and you can see it specifically here, is how they line up. That's actually a result of how they're dividing, and that's called palisading. Again, most of these are opportunists. It is unusual to find Corynebacterium causing an infection. Not impossible, but unusual to find it. And really what we want to see is multiple specimens with that. I remember once having an eye from a nursing home patient that had a moderate amount of Corynebacterium in it, and just saying, oh, it's just a moderate amount of Corynebacterium. So they sent another culture. It was the same thing. So in that case, she might have Corynebacterium in her eye. It's unusual, but it can happen. There are, however, we do know about pathogens. Diphtheria is the most famous, which causes diphtheria. Major outbreaks of diphtheria in the 19th century in Europe, and a lot of it having to do with poverty and close confines. There are others that we commonly find: bovis, ulcerans, xerosis. JK is a serious one. JKium is pronounced. That's a serious one we do have to look for, especially in the elderly in their urine, that it can cause a problem. Then we have pseudodiphtheriticum and pseudotuberculosis. These are the guys that you're going to find. Diphtheria causes diphtheria, but the rest of them, you may find them in small amounts and it doesn't mean anything. Diphtheria itself can cause two forms of disease, respiratory and cutaneous diphtheria, but we've had a vaccine for diphtheria since the 1940s. Okay, so we are very uncommon to find this, and for that reason, we probably wouldn't keep the special the special medias that we would need in order to identify diphtheria in our laboratory. So we would probably send it out. There have been outbreaks of diphtheria, in particular in countries where immunization is not complete. And since immunization now in the United States frequently is not complete, that could in the future include us. Okay. Basically what happens is the organism will be carried in the upper respiratory tract, and you can spread it. You got it from another human. Okay. It needs a human host to cause the disease, and it'll be spread by hand to mouth or droplet infection. So you cough in your hand, you shake somebody else's hand, it can be spread pretty easily that way. But humans are the only natural host, so you didn't get it from playing with your puppy or anything like that. It originally was known as the Klebs-Loeffler bacillus. Those were the fellows who first discovered it in 1884. These were German bacteriologists. But then, sorry, Klebs and Loeffler, they lost all their credit. Okay. We do have special stains to visualize this. You could do it potentially in a throat specimen or something like that, and it's called the Albert stain or Ponder stain. These are special stains. You don't need to know the procedure, but what they do, this is a slide of the Albert stain. What you're doing here is you're identifying what are called metachromatic granules. The organism still looks like this up here in this picture. It's flat. You don't see any spores. No spores. In the Albert stain, it kind of looks like there's spores, and they're not spores. These are called metachromatic granules. These are polar regions that develop only with this stain. Okay, we don't see them elsewhere, but only Clostridium does that. So it's helpful to identify them. The infection itself is actually, it's pretty benign to start with. You might have a sore throat, you know, it'll feel like you have strep throat or something like that. I got a low-grade fever, sore throat, I don't feel good. And the organism is growing in your tonsils, in your pharynx, multiplying pretty rapidly, actually. It goes through a pretty dramatic log phase. And then it starts to produce a diphtheria toxin. This is an incredibly potent toxin, and it's capable of blocking protein synthesis in the hosts. So what happens then as the infection develops and protein synthesis is inhibited, cells die. So it leads to tissue necrosis and an inflammatory response. And an exudate is produced from the inflammatory response that produces a very tough gray to white pseudomembrane, and you can see it forming here in the throat. You can see it back and forth, a little bit sticky there. This pseudomembrane is forming and attaching to the tissues in the pharynx. Okay. So that membrane, just that membrane alone, is capable of causing suffocation. In addition, in case that's not enough, the toxin can also be absorbed into the bloodstream and then go to the heart, and you can end up with a pretty serious problem in the heart. So death can occur from cardiac failure. Corynebacterium, no, I don't need to know this. Oh. Not every strain actually produces the toxin. The diphtheria toxin is actually encoded by a phage found only in certain strains, and that would be then the toxigenic strains would have that phage DNA integrated into their own chromosome. Okay, so the phage, or I should say well, it doesn't matter. So it's not every single toxin, every single strain that you see creating this toxin. The treatment actually has to do with getting rid of the toxin. So you have an antitoxin that has to be administered to prevent that toxin from producing those membranes. Wherever it wants to, it could produce the membrane in the throat, in the heart, wherever, but it'll block function. And then you use an antibiotic to prevent the organism from spreading. So penicillin or erythromycin will work fine to kill off the bug. But by far the best method to prevent this is immunization. And they found that we can see significant reduction by using a product of the bug itself, the actual toxin, and we generate an immune response against that toxin, and it's very effective. Basically, it was discovered in 1929, and a fella actually named Ramon actually was able to demonstrate a conversion of a toxic form or effective form of the diphtheria toxin to a non-toxic form or non-effective form by combining it with formaldehyde, which also happens to be a good adjuvant, and that's where you get diphtheria toxoid, which is the vaccine that you received today. You can see here, this is just some charts to show you the reduction in diphtheria cases in the United States as we have using the antitoxin in the early 1900s. Okay, and again, if you look, this is a broader chart at the top here, but if you look at this chart on the bottom, you can see that there has been an uptick in the center there associated with those who don't want to take vaccines. But we're getting better and better. The cutaneous diphtheria, which is, it's really not common. It's associated more with the tropics. It's not common here in this area, and certainly not as common as the respiratory form, but it is something that they do see from time to time in the tropics. I guess maybe because people wear, they don't wear as much clothes, shorts and flip-flops and stuff like that. So their skin comes in contact with the dirt more often, okay? But you end up with these ulcers that form from this infection. So the infection actually, the toxin is there and it's killing tissue and it's creating this ulcer that won't heal. And then over time, you actually, in which you can see in this picture here, you can see a gray, filmy membrane forming over the ulcer. Okay. Unfortunately, it can lead to a loss of nerve function and feeling around the ulcer. These are the one on the left is not a terrible ulcer, but the one on the right is a pretty well-formed, well-developed ulcer. And they also see this more common. We're seeing this more commonly in the Northeast with homeless persons. So with those people, people who unfortunately don't have the wherewithal to keep the dirt off of them. So Clostridium diphtheriae, to identify it in the laboratory, microscopically, this one's going to be one of the more pleomorphic. So you can see it's not as even as other Clostridium will be. You can see the granules at the surface, and you can see also it's kind of sloppier, okay, looking. And that has to do with actually some of the snapping that occurs as it snaps apart on the long axis. It tends to sort of jump farther apart. Some of the things that you're going to see are the Babst-Ernst granules, which are just those highly staining, they're not spores, but it tends to look a little bit like a spore at the end, okay? And you still get the palisading where they line up, just not as visible here in this particular field, but you start to see some of the palisading. That definitely still occurs. It is still Corynebacterium, okay? In order to grow these specifically, if a doctor was looking specifically for diphtheria, we would need some agar containing tellurite. And there are a couple agars that are available. They're called, one of them is called cysteine tellurite agar. That should tell you that it contains tellurite. But also Tinsdale agar contains tellurite. And when it grows, it can grow actually on nutrient agar, but it generally needs some agar, some blood, some serum, something like that in order to grow. So we have Loeffler's medium obviously can grow Corynebacterium, CTBA, which is cysteine tellurite blood agar. These are things that'll grow the diphtheria pretty easily. And those are both selective and differential. If it contains tellurite, you'll see that it'll grow with a black precipitate or a brown halo, either of those. And that's usually the cystinase activity. Actually, one of the other things that's different about these agars is that they're, instead of maintaining it at a neutral to very slightly acidic, you're actually going to see these are much more alkaline. You can see the pH at 7.8 to 8.0. That's significantly different. It'll keep most other bacteria from growing. And these require oxygen, so these will grow in your aerobic conditions. The biochemical identification, you're going to do a catalase. Catalase is going to be positive. Corynebacterium is catalase positive. They're non-modal, okay? You might see some Brownian motion when you do a germ tube, but they're non-modal. And on the CTBA, that cysteine tellurite blood agar, you're going to have that brown halo. That would be here, okay? Also, the urease. We do a urease sometimes, and urease would be negative for diphtheriae, whereas other Corynebacterium like ulcerans and pseudotuberculosis, those are both urease positive. So we like to see a negative urease to get at least a presumptive ID for diphtheria. Then we also look at the glucose and the maltose. Diphtheria can ferment both of those. There's other combinations for the other Corynebacterium. Now, just because you have Corynebacterium growing in your throat doesn't mean that it's producing the toxin. So in order to test for the toxin, which is really how you diagnose diphtheria, you actually have to demonstrate the diphtheria toxin. And in order to do that, they have what's called the ELK test. The ELK test is the standard, that's what we have used, but obviously these days we have PCR. So you could just jump directly to PCR. But you need to know what the ELK test is. The ELK test is, and I have this cartoon here for you, you actually have strips that are impregnated with with antitoxin in it. And you grow your organism, you just put some streaks of organism. The top streak, if you look at the thing, the top streak is a known toxigenic C. diphtheria. The middle streak, sorry, is your patient, and the bottom streak is a known non-toxigenic diphtheria. And you're going to look for precipitin lines, lines of identity that form between the actual organism. So if the organism is toxigenic, you'll see lines of precipitation between the two here. Okay. Again, today we have PCR. Just do PCR and you see if it contains that Phage gene. That's pretty easily done. Okay. We don't do the ELK test in a clinical lab because the ELK test, we have less than 5 cases per year so far in the United States. So if you suspected this, you would send it to a reference lab to test for the toxin or for test for toxigenicity. Okay, and that'll be done by the local health department, not by the routine lab. Now, one of the unusual ones is Corynebacterium jacqueum, or JK is what we call it. It is normal skin flora. It is part of the normal skin flora. However, we do have to rule it out in blood cultures and in pure growth cultures or nearly pure growth cultures. We do see this in immunocompromised patients. We see, or in patients who've had invasive procedures, like maybe a catheter or a prosthetic device implanted, or we do see them in IV drug users. It is pathogenic, although only in an opportunistic infection. So most people, it doesn't cause a problem. However, in those who are immunocompromised, it has the ability to reach the pretty significant levels of infection. Okay, we do see this probably most frequently in bone marrow transplant patients who have almost no protection, and this is skin flora and it's able to get through, and it can produce bacteremia. Unfortunately, or fortunate, I should say fortunately, it's usually pretty, it is susceptible to vancomycin and tetracycline, but we do see resistance to, penicillin, cephalosporin, aminoglycosides, and some macrolides. It's pretty often that's the case. So you might have to use a higher level antibiotic in order to treat this. Probably one of the most common populations is actually our neutropenic patients who have an intravascular catheter and prolonged neutropenia. These are the patients where we have a problem. We can also see this in patients, it is lipophilic, so in patients who are receiving, so for example, when you have your patients who are undergoing bone marrow destruction, as the bone marrow is destroyed, lipids are reduced, and that's really what feeds the bug, because it really does like those lipids. So you do have to actually watch for this, be careful to watch for this in patients who are either undergoing bone marrow or who are on some lipid therapy. That's positive as well. That's possible as well. These would be catalase positive, just like all Corynebacterium. They're mostly non-modal. Occasionally we do see an isolate or two that is modal. So it is something that we watch out for in the immunocompromised. I've seen it in patients who are from nursing homes once or twice from their bladder because they have a catheter inserted for their whole life. So these are one of those things that can occur.